Okay, it's 9 a.m. We'll get started. I think we're just waiting on KK to join, but we have four of us at least, so we can get started. All right. Good morning, everyone, and welcome to the January 8th, 2026 Licensing Committee meeting. My name is Sung Oh, chairperson of the committee. I would like to welcome KK Ja to our committee. We look forward to your contribution and considering what agenda item we have today. I believe it is a good timing for him to join this committee whenever he joins. Hopefully, I will repeat myself so he can feel welcome. And before we continue, I would like to remind everyone present that the board is a consumer protection agency charged with administering and enforcing pharmacy law. Where protection of the public is inconsistent with other interests ought to be promoted, the protection of the public shall be paramount. As I facilitate this meeting, I will announce when we are accepting public comment. I have advised the meeting moderator to allow 2 minutes to each individual providing comments. Over the past several meetings, the board has faced time constraints resulting in deferral of discussions. To address this, we are reducing public comment to 2 minutes. As a reminder, as included in agendas, the board provides contact information for individuals to provide written comments in advance of meetings should they choose. Thank you all for your understanding of this change. We'll begin with public comments for individuals attending in person, followed by comments by individuals participating via WebEx. This approach is necessary to facilitate this meeting. Before we get started, I would like to ask staff moderating the meeting to provide general instructions on the process for providing public comment via WebEx. Moderator?
Thank you, Chair O. Before we get started, I would like to remind board members and staff who are not speaking to mute their microphones during today's meeting. If background noise is detected as a result of unmuted microphones, I will mute those microphones. There are members of the public in the audience and meeting minutes are being taken, so we ask members and staff to please identify themselves before speaking. For purposes of today's meeting, when the chair opens public comment, members of the public who would like to provide public comment at the physical location can approach the table and microphone at the front of the room. For those joining us on WebEx, we will be utilizing the hand raise feature. When public comment is called, you may click on the hand icon next to your name, or if you've called in, press *3 to raise your hand. And we will take public comment from the physical location first, and then request public comment from those joining us through WebEx. And with that, I return the floor back to you.
Thank you, Tricia. I would like to take a roll call to establish a quorum. Satinder Sandhu, Vice Chair Satinder Sandhu,
This is Satinder Sandhu, licensee member present.
thank you, Satinder. Renee Barker,
Good morning, licensee member present.
thank you, Renee. Jessica Crowley, I believe Jesse is not joining today. KK Ja, I know KK is trying to join. He's having technical difficulties. So
Good morning.
Oh, thank you, KK.
I'm here.
Thank you, sir. And Claudia Mercado.
Present, public member.
Thank you, Claudia, and I am here. Appreciate everyone joining today. A quorum has been established. Members, we have a full agenda item for our meeting today. I ask everyone participating today to be respectful of the work before the committee. We encourage participation by members of the public throughout our meetings at appropriate times. The committee respectfully requests that when comments are provided, they're done so in a professional manner consistent with how the committee conducts its business. Also, since we have another meeting scheduled today starting at 2 p.m., this meeting will have to end at around 1 p.m. to provide necessary breaks. Before we move to the next agenda item, I would also like to remind board members participating via WebEx to please remain visible on camera throughout the open portion of today's meeting. Members, if you need to temporarily turn off your camera due to challenges with internet connectivity, please remember to announce the reason for your non-appearance when you turn off your camera. Tricia, just checking to make sure everybody can hear me because all members turned off on my end on my maybe I'm having a internet connectivity challenges.
This is the moderator, and I can hear you loud and clear.
Okay, strange things are happening, but hopefully everybody can see members. Just it's having my issues. Can you all see members? Can
I
we
can
make sure the room can hear us?
Sung, yes, we can hear you
Okay.
fine and we can see all the members. Thank you.
Okay, great. Thank you. Okay, moving to agenda item 2, public comment on items not on the agenda items for future meetings. I will now ask the meeting moderator to open the line for individuals to provide the opportunity for public comment on items not on the agenda. You're not required to identify yourself, but may do so. I would like to remind everyone that the committee cannot take action on these items except to decide whether to place an item on a future agenda. Accordingly, if your comment pertains to an item on today's agenda, please save your comment for the public comment period specific to that agendized item. Members, following review of the public comment for this agenda, I will ask if members to comment what, if any, items should be placed on a future agenda. As a reminder, this agenda item is not intended to be a discussion, rather an opportunity for members of the committee and members of the public to request consideration of an item for future placement on an agenda, at which time discussion may occur. Are there any members of the public in Sacramento?
No members of the public in Sacramento. I will
Thank
advise you
you.
if that changes.
Thank you so much, Anne. Moderator, we're ready for public comment on WebEx.
Thank you so much. If any member of the public would like to comment on an item not on the agenda, please raise your hand by clicking on the hand icon next to your name, or if you've called in, pressing *3. We are displaying instructions and we'll give you a moment. All right, I see no request for comment at this time. Mr. Chair, I return the floor back to you.
Thank you, Tricia. Members, do we have any other thoughts, suggestions for agendizing any items? Seeing none, we're ready to move on to agenda item 3, discussion and possible action to approve minutes of the October 15th, 2025 committee meeting. Happy New Year, forgot to say. Members, as we begin our consideration, I will ask if members have questions or comments on the draft minutes from the October 15th, 2025 meeting found in attachment 1 of the meeting materials. I would also like to entertain a motion if you believe such action is appropriate. Members?
No comments.
Would you like to make a motion, Satinder?
A motion to approve the minutes from the previous meeting.
Thank you.
I'll second that.
Thank you.
This is
Thank you, Renee.
Mhm.
Okay, with a motion and second, we're ready for public comment. Sacramento, there is none, so we're ready for public comment in WebEx.
All right, if any member of the public would like to comment on agenda item 3, please raise your hand by clicking on the hand icon next to your name, or if you've called in, pressing *3. We are displaying instructions and we'll give you a moment. All right, I see no requests for comment. I return the floor back to you.
Thank you so much, Tricia. All right, members, we're ready for votes. Satinder, how do you vote?
Yes.
Thank you, Satinder. Renee?
Yes.
Thank you, KK.
Yes.
Thank you, Claudia.
Yes.
Thank you, and I vote yes, motion passes. Okay, moving on to agenda item 4, discussion of proposal to establish definitions for pharmacies based on business model, including presentations on the following business models. First, home health services, presented by Dr. Janice Dang, our Chief of Enforcement for the board. And second is skilled nursing facilities, again by Dr. Janice Dang, our Chief of Enforcement for the board. And lastly, but not least, third, infusion centers, Dr. Sam Martinez from UCSC's outpatient infusion pharmacy manager. As we have previously discussed, Generally, the requirements for pharmacies apply equally among a variety of business models, unless otherwise specified. This approach allows for broad regulation, yet can become very challenging when business models vary, but requirements many times do not. Within existing law, there are several instances where a more specific definition is referenced, but only when applying to a specific provision of the law. The meeting materials also provide an example. Law does not currently include a general definition of chain community pharmacy. Rather, in specified sections of statutes and regulation, the law refers to BPC Section 4001 for the definition. Note, BPC 4001 provides, for the purposes of this subdivision, a chain community pharmacy means a chain of 75 or more stores in California under the same ownership, and an independent community pharmacy means a pharmacy owned by a person or entity who owns no more than 4 pharmacies in California. During the committee's October 2025 meeting, the committee considered various pharmacy business models, as well as a distinct model related to infusion centers. Following our discussions, these items have now been combined. As I stated during our prior meeting, I believe there are pros and cons to establishing definitions based on business models. As I've stated many times, I'm a proponent of maintaining a broad licensing scheme. But I also understand the value in developing definitions that could result in more precise and exemptions of certain regulation of pharmacy requirements or statutes. You may recall, during our prior discussion, the committee noted that development of definitions could allow for more precise regulation and provide better transparency to patients regarding the types of services a pharmacy provides. As we continue our discussion and education of this issue, today we'll have 3 presentations. We are going to taking things a little bit out of order. So I'm going to start first, welcome Dr. Sam Martinez of UCSD to provide the presentation. Dr. Martinez, the floor is yours. Again, Dr. Martinez is Infusion Pharmacy Manager at UCSD, UC San Diego Health out in San Diego. He's close in my vicinity, so thank you for joining us and welcome. Dr. Martinez, the floor is yours.
Good morning. Thank you for inviting me. I'm Sam Martinez. I'm an Infusion Center Pharmacy Manager at UC San Diego Health, and I'd like to thank the board for inviting me to speak today. I was asked to come present on infusion center operations. The next slide. Today, I'll provide a brief operational overview of how infusion center pharmacies deliver patient care, and then highlight where current California pharmacy law may have opportunity for evaluation. Importantly, these challenges are not about gaps in safety or quality. They stem from a regulatory framework that was designed around retail and inpatient hospital pharmacy models, which kind of vary from what current infusion center practice is. The goal here is kind of clarity on what infusion centers do and how patients are protected, and why certain regulatory requirements could better align with actual clinical operations. Next slide, please. For the purpose of this presentation, I'm going to focus more on traditional infusion centers, not home infusion. Infusion centers provide on-site preparation and administration of parenteral therapies, things like monoclonal antibodies, biologics, and chemotherapy products. Care is delivered under a physician order treatment plan with pharmacist verification and clinician administration. The most important distinction is that the medications are not dispensed for self-administration at home. There's no retail transaction. Everything's prepared and administered on-site under direct clinical supervision. That distinction, I think, is foundational to understanding why certain retail pharmacy requirements do not necessarily translate well to infusion practice. Next slide, please. From a patient care perspective, infusion centers operate in a closed loop kind of clinical model. A provider establishes the treatment plan, pharmacists perform clinical and safety verification steps. Medications are compounded under USP 797 and 800 standards and then handed directly to clinicians such as nurses for administration. Patients are monitored in real time during and after the infusion. This workflow emphasizes immediate use, interdisciplinary oversight, and continuous accountability, which is different from a dispensing and counseling retail model. Next slide, please. Under current California law, the concept of pharmacy regulation is directed toward more of a community pharmacy, which is largely focused on retail chain pharmacies or a hospital inpatient pharmacy license. Infusion centers are kind of a hybrid of these two environments, but doesn't fit necessarily either category neatly. They're forced to carry a community pharmacy license that was designed for retail pharmacies, but in function more closely resembles a hospital pharmacy. They're ambulatory, outpatient, and clinically focused hospital-level care, yet they're required to operate under licensing frameworks built for more retail environments. This kind of creates a structural mismatch. Infusion centers must comply with requirements that assume a walk-up consumer point-of-sale transaction is taking place, none of which reflect infusion operations. Next slide, please. Rules governing a community retail pharmacy are designed for open consumer-facing environments. Infusion centers, by contrast, operate as restricted clinical suites. Patients are scheduled, escorted, and treated under direct clinical supervision. Counseling is interdisciplinary and occurs as part of the treatment, not a retail counter. Applying these retail constructs does not improve safety and often creates operational confusion among various professions operating in the same space, such as nurses, doctors, and pharmacists. Next slide, please. Many pharmacy requirements are written with the retail model in mind, but they do not translate cleanly to an infusion or health system setting. Elements like public consultation counters, walk-up signage, retail pricing disclosures, and even 18-point patient-facing labels assume self-dispensing and consumer interaction at a counter. In infusion care, patients receive medications on-site under direct clinical supervision, and medications are not for self-administration. Applying retail-specific standards in this context increases operational burden without necessarily providing a corresponding safety benefit. The question isn't whether standards are important, it's whether they're designed for that care model they're being applied to. Next slide, please. Another area of misalignment is labeling. Retail pharmacy law emphasizes patient-readable labels, translations, and auxiliary warnings because patients self-administer the medications at home. In infusion centers, labels exist for internal identification, verification, and nursing administration, not patient interpretation. Patients receive education directly from a variety of clinicians, including pharmacists, as on-site part of care. Requiring retail-style labeling standards adds complexity without necessarily enhancing patient understanding or safety. Next slide, please. Retail-based staffing rules also create challenges. These include fixed technician ratios, posted lunch closures, and chain pharmacy staffing disclosures. As I said before, infusion centers operate more like a hospital, I would say, in those regards, with staffing aligned to sterile compounding workload, patient acuity, and clinical flow, much like hospital pharmacy model. Retail staffing constructs can disrupt care delivery and do not reflect necessarily how the infusion services operate. Next slide. Many scope of practice requirements embedded in pharmacy regulation currently assume a community retail dispensing model that simply does not exist in infusion practice. Activities such as cures, dispensing workflows, emergency contraception, CLIA waive testing, refill authorizations, auto refill programs are core to retail pharmacy operations, but they're not typically performed in an infusion center. Infusion pharmacies do not dispense opioids directly to patients, authorize refills, or engage in episodic opioid prescribing. and medication is all administered under direct supervision. Infusion pharmacies operate under provider order treatment plans with non-refillable medically supervised dosing. Applying retail scope requirements in this context creates a mismatch between regulation and actual clinical practice. This is not a request for exemption from oversight, it's a request for alignment. Scope of practice requirements should reflect the services actually provided and the risks actually present in the care setting. Next slide, please. To be clear, infusion centers should absolutely be regulated, but the focus should be on the areas that truly impact patient safety. That includes USP 7900 and 800 compliance, sterile compounding environments, hazardous drug handling, order verification, quality assurance, and adverse event reporting. Infusion centers already operate at hospital-grade standards in these areas. The issue is not deregulation, it's a regulatory alignment. Aligning oversight with the actual infusion practice improves safety, clarity, and patient access. Next slide. In summary, the challenge is structural misalignment, not lack of regulation. Infusion centers are clinically supervised treatment environments, yet they're regulated under a framework designed for retail dispensing and walk-up consumer access. This results in compliance obligations that do not reflect how care is delivered, diverting time and resources away from the areas that matter most for patient safety. The board's own self-assessment tools illustrate this mismatch clearly, with extensive retail requirements applied to settings where medications are never dispensed for self-use, leads to pages and pages of NA on the self-assessment forms. Aligning regulation with infusion practice would improve clarity, reduce unnecessary burden, and allow regulators to focus on sterile compounding, hazardous drug controls, and clinical safety, where oversight has the greatest impact. When you have the majority of the statements marked as NA, then you know it's time for another look at the structure. Next slide. So in closing, the question is not whether infusion centers should be regulated, but whether they should be regulated under the right model, and a new licensing category would better align with these two frameworks. As compounding regulations get more complex and new cellular and gene therapy modalities are introduced, and accounting for technological advances involving robotics and other technologies, the gap will only widen between infusion practice and retail practice. Infusion pharmacies are now being asked to help assess, prepare, and monitor complex gene and cellular therapies that are stored in things such as -70 freezers, cost several millions of dollars for one dose. And so let's help move and modernize the regulation of infusion pharmacies to better alignment with a future where infusion pharmacies are becoming a critical part in decanting inpatient cost-heavy administration areas and allowing patients to be cured in a safe space and go home to their bed that night. Thank you.
Thank you, Dr. Martinez. I really appreciate you keeping it quick, short, but also very important in the contents. I really appreciate your time and providing education to the committee about your infusion pharmacy. Members, do you have any questions or comments for Dr. Martinez? Claudia, go ahead.
Hi, Dr. Martinez. Thank you for your presentation. Can you just tell us a little bit more as to what you see the bigger changes that are coming? I know you mentioned there's these new therapies with, you mentioned refrigerating certain things below, what was the number you mentioned?
-70 freezers. And,
Freezers. Can you just elaborate more on what is ahead for us to consider?
yeah, I think the direction of healthcare is to, with the inpatient hospitals being overwhelmed with patients and not having the number of beds, the direction is to try to get patients treated in the ambulatory space, where I think infusion centers can play a huge role in providing care for a lot of things that patients previously would have to be admitted to a hospital, spending nights away from their family and a comfortable environment. Whereas now we're heading in a direction where these complex therapies are being given in infusion centers, where we provide monitoring and follow-up to make sure that they're safely given in a controlled environment.
All right, thank you.
Thank you, Claudia. KK?
Good morning, Dr. Martinez. Thank you for that presentation. I am particularly interested to know about labeling difficulties you mentioned, and are they coming from operational point of view with regards to not having enough real estate on the label, or is it regards to patients or the nurses not able to follow all the instructions printed on the labels? Where is it stemming from?
Yeah, I think you identified it exactly. So it's all about real estate on the label. There's only so much space on a label. So when you have to get all the different elements that are required on the label, including font size and all that sort of thing, you kind of run out of real estate, and maybe things that are actually more important that could go on the label aren't have to be cut from the label. So I think that's where we could have some improvement.
Okay, thank you. And you mentioned something regarding ratio, pharmacist to technician ratio, and also I think in the very next bullet point, if I recall correctly, was also about uh, infusion pharmacies working on a patient schedule and administration. Um, can you connect those dots for me? Why ratio and the need to provide dose at particular time matter?
Yeah, I think what I was referring to is I know the board is looking at hospital pharmacies and how they operate on the ratios with pharmacists and technicians. And I really think infusion pharmacies operate similar to hospital pharmacies in that manner, where they're doing a lot of different non-traditional tasks. So I think when we're looking at infusion center ratios, we should align that more with what's happening in the hospital pharmacy space.
Thank you, Dr. Martinez. No
Thank
more
you,
questions,
KK.
sir. Thank you.
Thank you, and we'll go to Satinder.
Hello, Dr. Martinez. Thank you for the very thorough presentation, just like Dr. O pointed out. I just wanted, I do agree that we do need a different set, treated differently, because it creates a burden, not necessarily provide any protection for the much protection for the consumer. My question is that doing so, we don't want to create something that would actually make things worse. If I understand right, I could be wrong. In current scenario, you are issued a community pharmacy license, and you would be able to dispense to the patient something that's not self-administered. They could self-administer. For example, let's say patient comes into the infusion center and they get infused and they have some sort of site rash and cream is prescribed, they can go home. Within this new scenario, would that be prohibited, or would that be impacted, or it just came to my mind, that's all.
That's actually a great question, Satinder. Possible unintended consequence, right? Yeah.
Yes.
So I guess to answer your first question, in the infusion center, we have two licenses. Currently we have the community pharmacy license and then a sterile compounding license. For ancillary medications, such as take-home medications, that would, in a proposed model where if we had separate licensing, that would be filled in a community pharmacy, retail pharmacy space, separate from the infusion center.
I guess before I get on any little more further of this topic, I think from my last discussion as a committee, we are not really looking at creating a new license, more as a exemption based on a business model, as we will continue to discuss during this meeting. However, I suppose there are, if the members prefer the other approach, we can look at least one category of licensure, but I do think that that's going to get a little bit more challenging. So I think that's where we will have to talk more about it as a board and as a committee. So currently, PHY is basically for everything that's not a hospital license. And for PHY, could be infusion centers, could be a pharmacy, outpatient pharmacy, could be a chain pharmacy, could be a pharmacy that only does compounding. And again, as Dr. Martinez alluded to, it could be a infusion center pharmacy. And so I think that from previous discussion, license category differentiation was going to be a little bit more challenging. And so I think we were hoping to land in where we do not create another license type, but would allow them to be exempted from certain requirements that they are that we deem as probably unnecessary for their business model. I hope that makes sense for everyone listening. So I think that's the hope from the previous discussion. Again, we can change, but I think that's where we are at this point. So just want to make sure I put that out there. Does that make sense for you, Satinder, and everyone? Hopefully.
Yeah, I agree 100%. I think instead of creating a separate category, we can go, this would allow us to create exemptions, because I don't want to create a new unintended consequences where, as Dr. Martinez pointed out, they would be, if we were to create a separate class, and let's say that patient now needs to get it at the community pharmacy, the second product, it could actually not be convenient for the consumer and possibly, burdensome. So that's where I was going. So exactly.
Got it. Right. Yeah. I mean, I think that also, as you can see from the definition draft, it gets really confusing once you start really defining a license category based on a business model. It gets, I mean, like some states like Texas has this, and they have like 10 different license types. And what do you do if you do both, right? So, I mean, sure, there's ways for them to go through with this, but I think our model has been, and I've been very hesitant to bring this up for a long time, because once you really go down to nitty-gritty of all this, it gets extremely complicated, and a lot of unintended consequences are out there. So I think that gets really tricky. That's why we're having this presentation. Sorry, before I ramble on, I think Dr. Martinez, anything you would like to add? I'm sorry that I would like to provide you with the opportunity, and hopefully you can stay as well, but you probably have some time constraints, so I understand if you have to go, but we are having a more holistic discussion of the definition. So okay, Renee, I have your hand raised, but just want to make sure, Dr. Martinez, did you want to add anything or say anything to that? Because I want to make sure that I would like to make sure your perspectives and challenges are heard on this topic.
No, I appreciate you guys taking a look at this topic and trying to improve this current situation, whatever that improvement becomes. I know I was trying to do some research about what other states are doing. I know Maryland had a pretty thorough kind of definition structure for infusion pharmacy. So that might be a good place to reference it. They don't have a separate license, but
okay,
they do have a separate section.
Got it. Okay, I have a lot of questions for Corinne as well. So sorry, Corinne, I'm just giving you a heads up. I have a lot of questions that comes to my mind how we would actually operationalize this. Renee, you're next.
Oh, hi. Thank you so much for the presentation and for so succinctly kind of demonstrating where there's not crossover between community and the actual operations there. And I would say in listening to this as a hospital pharmacist, I mean, I can see that there's like a large chunk of it sounds like what's happening inpatient. Just the patient proximity is similar but different, right? But I can see where this so much aligns with a lot of hospital. And yes, as infusions get bigger and bigger, as they say, right? In terms of complexity, in terms of storage, in terms of cost, right? And there's just and monitoring the patient, et cetera, right? So I think this is a really great presentation to help kind of elucidate that contradiction of those two things. And yes, I mean, labels, I'm glad that got brought up. Always so key, right? There's so much you would like to put on a label, and you only have so much real estate, and font size matters. So you know, I understand that as well. So anyway, thank you again for the presentation.
And Dr. Martinez, I have one naive question, please. I'm probably embarrassing myself for this, but I really am not familiar with this space, so I'm going to ask, how does the cures work with your operation? Like I'm guessing it's not dispensing, quote unquote, so do they not get reported if you do provide controlled substances?
Right, since we're not dispensing to patients. Well, I mean, at least it depends on what you're doing. I mean, I guess some places could be operating under their retail rights and be dispensing to patients. But if you're not, then you probably wouldn't have any cures involvement.
Got it. And for your operation is really purely people are there with the products you guys make, are there infused at on-site, right? At a minimum, or do they get to use and take it home and get a home infusion from the products you provide?
No, that would be home infusion,
Okay.
which is a whole nother discussion.
Yep, it is. It is. Yep. So you guys are
But
purely, they're all on
I
site.
think
Patients are all on site.
to Renee's point, you know, that might be another thing to look at. You know, should infusion pharmacy be under the hospital pharmacy branch? I know there's, what is it? I think you guys have a separate licensing
Oh,
for.
that opens a whole can of worms, Dr. Martinez. Oh my God. I don't think we're gonna get there. That's gonna be okay, well, a lot of food for thoughts here. Lot of food for thoughts. Okay, that provides very important information. Also, if you can provide like specific business and professions code sections and the CCR section, specific codes that pertain to each of these challenges you are providing, that would be very helpful in our future as we move forward. Just drop it to us when you have a minute with all the compilation of the pertinent sections of the law, because we're going to have to figure out how we actually move forward with this. If it is a BPC, I don't know how we move forward it exempting other than using a statute. So it's going to get a little bit complicated. It's going to be a long process. So please bear with us. But I'm hoping that at least a technician ratio change is going to be a little bit helpful for your operation as of January 1st of 2026 in providing the best care possible. I know a lot of, you know, it's always the technicians compounding. So I'm hoping that at least helps a little bit. So, okay, members, before I go to public comment, any other comment before to Dr. Martinez? Okay, Dr. Martinez, as a public agency, the board is required to accept public comments on each item, and public comment is not intended to be a question and answer session. However, they may ask questions and you are under no obligation, but you are welcome to respond. So I don't think anyone is still in Sacramento, so we're ready for public comment in WebEx. Tricia?
All right, if any member of the public would like to comment, please raise your hand by clicking on the hand icon next to your name, or if you've called in, pressing *3 or displaying instructions, and we'll give you a moment. Just a reminder, you'll have 2 minutes to make your comment. I'll give a 10-second warning, and I do see a raised hand from John Gray. So John, you should be able to unmute yourself.
Hi, good morning. This is John Gray, registered pharmacist with Kaiser Permanente. Thanks for the opportunity to comment. Just wanted to say that we largely agree with the issues that that Dr. Martinez flagged for the board to consider exploring, and also are generally supportive of the approach that President O outlined of kind of seeking areas for potential exemption for infusion pharmacy servicing infusion centers, rather than a separate category of licensure. We do agree that there are potential unintended consequences with creating additional categories of licensure, and so looking to exempt certain elements of the pharmacy law under for PHYs that service infusion centers might be a good middle ground. Thanks for the opportunity to comment.
Thank you for the comments, Dr. Gray.
All right. And we have no further requests for comments, so I return the floor back to you.
Thank you, Trisha. Okay, thank you, Dr. Martinez. We really appreciate your time. And I'm sure a lot more to come. So next is our Chief of Enforcement, Dr. Janice Thang. Some of you may not have met Janice, but she is a wealth of knowledge and just such a vast experience in so many areas. We're just so honored to have her as part of the board and our Chief of Enforcement of the board. Dr. Dang completed a residency in geriatrics with the Veterans Administration. And prior to working for the board, Dr. Dang worked as a consultant pharmacist and director of pharmacy for about 12 years and has experience as a home care and hospital pharmacist and many other experiences. Janice, we are so extremely fortunate to have you, and we will start your presentation on home health services. Janice, the floor is yours. Thank you so much, Dr. Dang. I don't hear Janice though, just so.
She's muted. Let me
Janice,
send
are you
her.
in the room or are you at home?
She's logged into WebEx. I believe she's at home.
Okay, and can you hear me now?
Oh,
Yes.
yep, we are.
Okay.
Yes.
Sorry, I had to call on my phone because my computer monitor is not working. So, good morning. Thank you for this opportunity. Uh, Unlike the infusion centers, the pharmacies that provide home health services are patients or possibly nurses that are infusing the drug. So the labeling and everything is more similar to like a community pharmacy because a patient is reading that label. So anyway, today what I'll be doing is going over what pharmacy home health services look like. Next slide, please. Okay, hold on. Okay, so this is the board's disclaimer. The opinions expressed in this presentation and on the following slides are solely those of the presenter and not necessarily those of the California State Board of Pharmacy. This California State Board of Pharmacy does not guarantee the accuracy or reliability of the information provided herein. This presentation, including examples, are provided for informational purposes only. The author makes no warranties, either expressed or implied. Information in this presentation is subject to change without notice, and this presentation carries no authority and shall not be considered legal advice. Next slide, please. So today, as an overview, I will provide a description of what services a pharmacy provides for home health, the types of patients they serve, the type of services offered, and the issues and laws specific to pharmacies providing home health services. Next slide, please. So for clarification, a pharmacy that is only licensed with the board as a pharmacy and provides home care services is not considered a home health agency. Title 22 California Code of Regulations, Section 74600 defines a home health agency is defined as a public or private organization that provides or arrange for skilled nursing services for individuals in their home, whether it's a temporary or permanent residence. Whereas Business and Professions Code 4027C defines the licensed home health agency, and the license is issued through the California Department of Public Health. So therefore, a pharmacy is not required to be licensed as a home health agency unless they employ or utilize their own nurses. Most of these pharmacies, a lot of the chain home health, yes, they're considered home health agencies and they're licensed as such. But there are pharmacies that provide home health care that do not have nursing staff. Next slide, please. So pharmacy providing home health services specialize in treating patients in their home or at a residential facility with pharmaceutical products and services. They are more, treating a patient at home is more cost effective. Most of these patients start their infusion therapy at the hospital and then are discharged home to continue the remaining of their therapy. Common infusions include, what they provide is commonly infusion therapy, administration of injectable drugs, parental nutrition, and enteral nutrition as well. It involves coordination of care and nursing between the nurse, the provider, the prescriber, and the pharmacy and the insurance. It pro- it involves training patients, family, and caregivers to infuse the drug or to show them how to administer the drug. It requires reviewing, dispensing, and delivering of drug therapies, patient monitoring, assessing proper storage of medication, providing consultation and education on the proper disposal of unused medications and supplies as well. It provides pharmaceutical products, supplies, and equipment, including pumps. Um, and as I mentioned earlier, many of them is if they're not licensed as a home health agency or a hospice agency, the pharmacy is not licensed as. If the pharmacy is not providing any nursing, then they are not licensed as a home health agency. Instead, many of them will partner up or contract with a home health agency for the nursing services. Next slide, please. To types of therapies, the type of patients that they are generally patients referred from the hospital discharge planners, from physicians, third party payers, licensed home health agencies, licensed hospice. Many of the pharmacies that are accredited by these organizations. Next slide, please. Services offers includes infusion therapy. It could be IV antibiotic, parenteral nutrition, chemotherapy, as well as treating pain. They can also provide respiratory therapy, hospice medications, primary pain and comfort meds, medicinal gases, enteral products, and ostomy and wound care products as well. Next slide, please. When a pharmacy gets a referral, usually it's an intake coordinator that will discuss with the referral agency or physician, whoever is referring the patient to the pharmacy. The intake coordinator, prior to accepting the patient, they'll obtain the patient's information, billing information, confirms their contract pricing or will negotiate the cost of a treatment. They will confirm the type of services that need to be provided and the duration. They'll confirm with the nurse if there's a nursing agency that that is already assigned by the insurance or by the discharge planner to provide the nursing care, unless the pharmacy itself is a home health agency themselves. The home health nurse generally does the education and the training to the patients on how to do infusion or how to administer their drugs. And then the intake coordinator will also discuss with the insurance company how many visits or nursing visits are approved, and they will contact. Okay, next slide, please. Sorry. Okay, the duties of the pharmacist, services that they provide, they obtain the prescription for treatment, they take the patient history, the list of medication, allergies, diagnosis, obtain their emergency contact. They determine types of access ports and supplies that's required for administration. So they'll determine if the patient has a peripheral line or a central line and how many ports they have to determine how many injection caps, and flushes and so forth for that administration. They'll obtain the orders for heparin flush if it's applicable. They'll contact the patient as well as the nursing agency to coordinate the delivery of medications to make sure that the medications are there before the nurse gets to the patient's home. Either the pharmacy or the home health agency will provide an introduction packet, which will include how to contact the pharmacist 24 hours, 7 days a week. It'll include the patient's rights and responsibility, consent for treatment, HIPAA information, and other paperwork. The pharmacist provides the consultation and treatment. They'll go over their side effects, what supplies are being provided to them, how to storage the products, and then coordinate the delivery. They oversee, in addition, the compounding of the dispensing medication. They routinely follow up with the patient or the caregiver, and then in most cases, they will have medical records or progress notes on the patients. Next slide, please. Issues related to home health services is following up with patients on the number of doses remaining to monitor compliance, scheduling the deliveries, coordinating the deliveries with the nursing visits, maintaining patient confidentiality when delivering medications. Under pursuant to California Code of Regulations 1752, pharmacists can carry and furnish to home patients dangerous drugs and parental therapy that's prescribed. Some home health agencies, the pharmacist may do the initial visit with the nurse to assess the home as well as the storage of the medication, if the patient has proper storage, if it needs refrigeration, if they can, is there room in the refrigerator to properly store it away from food products, or if they're required to have a separate refrigerator. Under California Code of Regulations 1753, if it is a licensed home health agency, they can have a portable container or like an emergency kit. It's more like a nurse bag, like a doctor bag, so that when they're going to the patient's home, that they, if say, for example, they are having difficulty starting a line on a patient and they may run out of supplies that the pharmacy provided, the nurse may have in their portable container additional supplies instead of having to come back to the patient's home and reschedule a visit. And with the use of, if a licensed home health agency has a portable container, one of the issues that is of concern is that they do store it properly, and that if they are using any supplies in there, that they return it back to the pharmacy so they can inventory and then restock. Next slide, please. Other issues is related to the obtaining of Schedule 2 controlled substances. There's 5 different ways of obtaining a prescription that requires the physician's signature. If the prescriber's signature is not on that document, then the pharmacy is required to follow Health and Safety Code 11167. So there is a challenge in retrieving or trying to get that prescription from the doctor, because after 7 days, if the doctor doesn't provide that, then the pharmacy is required to report the physician. Next slide, please. Let's see. The other issue is regarding partial filling for patients in home care. If they are a terminally ill patient, then the pharmacy can do partial filling. The pharmacy can also do partial filling pursuant to 4052.10 when they request for just a certain amount. And then 1745D, if it's a medication that's an injectable, that if the pharmacy is unable to fill the full amount, then within 72 hours, they need to send the balance. The other issues regarding pharmacy technician ratio, if the new law as of January 1st, it allows a community pharmacy, which is how these pharmacies are licensed, to have a 1-to-3 ratio. However, if you read the way 4115G2 reads, it talks about a licensed health facility or a patient in a licensed home health agency. So there's kind of a discrepancy here where if you are a licensed home health agency, then and you have a pharmacy, then your ratio would be 1 to 2, whereas a community pharmacy, it's 1 to 3. And then if you refer to our regulations, which is what 4115G2 talks about, our current regulation still says for a licensed home health agency, it's 1 to 2. Tracking, storage, and cleaning of these pumps is also a challenge. And that is the end of my presentation.
Thank you, Janice. Always appreciate it. I think that it's probably best just to focus on home health, and so we'll have members comment on it if there's any questions for Janice. No comments? Okay, well, we're gonna then just go for public comment, Janice, really quick, just on the home health presentation. I think I'm gonna have more questions after SNF presentations. Tricia?
All right, if any member of the public would like to comment, please raise your hand by clicking on the hand icon. Janice is still unmuted. I just muted her, so there we go. So if any member of the public would like to comment on the presentation, please raise your hand by clicking on the hand icon next to your name or pressing *3 if you've called in. And we are displaying instructions, and we'll give you a moment. All right, I'm not seeing any requests for comment. I return the floor back to you.
Thank you. All right, Janice, we're going to proceed to your next presentation. And so that is on skilled nursing facility pharmacies. Is that all loaded up? Perfect. All right, Janice, again, the floor is you again.
And this is the moderator. Dr. Dane, I muted you because there is an echo, so you'll need to unmute yourself again.
Okay, do I still have an echo?
No, it was causing me to have an echo with you being unmuted, so you're fine.
Oh, okay. Okay, thank you. So this presentation will address skilled nursing facility, also known as long-term care pharmacies. And just so that my background, as Dr. O said, is I worked prior to working for the board. I had many years of experience in long-term care, both as a consultant as well as a director of pharmacy. So anyway, next slide, please. Okay, and this is the same disclaimer, so I'm going to skip it. Next slide, please. And as an overview, I will provide a general description of a skilled nursing or long-term care pharmacy, the type of patients they service, the type of services they offer, and a review of the applicable laws that may apply to a skilled nursing pharmacy and the issues the skilled nursing pharmacy may encounter. Next slide, please. Skilled nursing pharmacies are currently licensed as a retail pharmacies whose license will begin with the prefix PHY. The pharmacy specializes in the management of patients' prescriptions who resides at a health care facility that is not considered acute care but requires nursing care. They can also provide services to residential facilities where nursing care is not required. Several skilled nursing pharmacies do service both patients in skilled nursing, long-term care, intermediate care facility, as well as residential facilities. Um, the skilled nursing facilities can offer services beyond what a community retail pharmacy offers and is often able to bill for services related to Medicare Part A, B, and D. Next slide, please. Okay, the type of patients that these pharmacies service is, if you look at this table, on the left side are facilities that are considered healthcare facilities where they are required to have nursing, whereas the facilities on the right-hand side are facilities that are more residential. Facilities that are considered healthcare facilities are either licensed by the Department of Public Health or Department of Healthcare Services, whereas the facilities that are considered residential and do not require nursing are licensed by the Department of Social Services or Department of Healthcare Services. Next slide, please. Okay, services provided. The pharmacy, this is more the skilled nursing pharmacy, the skilled nursing pharmacy providing services to skilled nursing facilities. They do prescription management. What? Excuse me. The skilled nursing pharmacy may offer licensed healthcare facilities such as 24 hours dispensing of prescriptions. They can use emergency kits where the law is permitted. They can install the use of an ADDS or automated unit dose system. They're required to have a consultant pharmacist to review their facility's chart orders and medication administration records, as well as the storage of medications. Some pharmacies provide a nurse consultant, IV therapy, in facilities that have what they call a distinct part, which is designated beds for Medicare Part A. They will have nursing that is able to provide IV therapy. They also provide enterourological and ostomy supplies. These facilities may have a house account for house supplies for their patients that they can use as a common stock of drugs. The pharmacy can install a drug take back receptacle for unused and discontinued medication for the disposal of medications that are left at the facility when a patient is discharged. And some facilities, not so many now that many of these skilled nursing facilities have electronic health records, but they have the capability of also printing the chart orders or the medication administration records for the facilities as well. Next slide, please. The skilled nursing facility pharmacy, sorry, can offer various packaging of medication. The most common are the bubble cards, also known as blister pack or blister cards. They can also fill prescriptions in prescription vials, med dose pack, which are similar to like prescription pill trays, and strip packs. Most pharmacies offer facilities the ability to have their residents' prescriptions to be filled as a month supply to begin on a specific date of the month. This is what they call cycle fill, and it's a form of auto refilling. For example, if the facility cycle is on the 5th of the month, the pharmacy will deliver a month supply for all their residents' routine medications. This helps with the facility not requiring them to call in for refills. And then cycle fills again are often dispensed in bubble cards. Prescriptions can also be dispensed on refund demand, which is as they exhaust or have 3 to 5 days remaining, they will call the pharmacy to request for refills. A lot of the PRN medications are refill on demand. The skilled nursing pharmacy can also offer repackaging of previously dispensed medication. When patients are admitted to a skilled nursing or intermediate care facility, the resident has a right to use their own pharmacy. So residents, when they're admitted, they are asked if they are bringing in their own meds, if their pharmacy could package it in bubble cards. Otherwise, they may require the resident to use the facilities contract pharmacy to repackage their medication in bubble cards. And this is more for, for convenience for the nurses when they're doing their med passes, as well as for inventory accountability. As for the use of AUDS, several pharmacies have installed automated drug delivery systems for the dispensing of routine and as needed medications. There's devices like the Taos Insight and Alexa RX that are the most common ones that will usually package it in these strip packs, where the nurse will request for the meds to be dispense for all their patients for their morning med pass. And so they will, have those meds being dispensed on a routine basis, whereas the Omnicell and the Cubex are more the AUDSs where they're unit dose. And the ones that we've been licensing, most of them are either being used for first dose or for emergency doses. Next slide, please. Okay, so here's the issues in regards to skilled nursing pharmacy. Because they service facilities that are licensed healthcare facilities as well as facilities that are residential, there is some confusion as when a chart order is acceptable versus a prescription. So in these healthcare facilities that have chart orders and have nursing, they chart orders is appropriate, whereas if they're in a residential facility where there is no nursing, they are required to have prescriptions, and those include having written prescriptions prior to dispensing, as well as getting authorized refills from the prescriber prior to refilling the prescriptions. Other challenges, similar to the home health patients, there's 5 different ways of getting prescriptions for controlled substances, um, and if they cannot get a signature on any of these prescriptions prior to dispensing, they should be utilizing Health and Safety Code 11167 and obtain a emergency prescription. Next slide, please. Dispensing limitation. One of the things with skilled nursing facilities is that they have stat order. Title 22 puts some limitations on the time that the nurse needs to administer the medication. So therefore, the pharmacy needs to get the drugs to the patient within that time. So stat orders are generally 1 hour if the pharmacy is open, 2 hours when the pharmacy is closed, that the nurse has to administer that drug. Anti-infective drugs to treat pain, nausea, and drugs to treat, excuse me, my voice, agitation, diarrhea, and other severe discomfort. Um, it the nurse is required to administer it within 4 hours. So then the pharmacy is, they have these time limits that they need to get the drug to the facility. So with the use of the ADDSs or the AUDSs, it has helped with expediting those orders to be administered, because the uh, excuse me. Um, Next slide, please. Sorry. Um, okay, another issue is with billing. Um, with the skilled nursing facility, billing is a little bit different. Patients that are on Medicare Part A, um, in 1997, Medicare changed their payment system to the prospective payment system. It calculates the average cost of the patient at each facility to determine their per diem rate for reimbursement at the facility. The facility rate includes the cost of medication. So therefore, when PPS went into effect, a lot of these pharmacies moved towards a per diem rate for the cost of drugs instead of billing each of the drugs individually. And so, for example, if the per diem was a rate of $10, the patient was in the Medicare Part A bed for 10 days, then for that month, the pharmacy would bill for those 10 days $100. High cost drugs tend to be excluded from the per diem rate. And to minimize waste, which is one of the challenges for these skilled nursing facilities, is that they'll send maybe a week supply at a time to try to minimize the waste, because they cannot take these drugs back once they're, once they've been dispensed. The other issues regarding preferential pricing of drugs, a lot of these pharmacies, when they set up their accounts with the wholesalers, they are asked if they want to join their uh, healthcare managed program that gives them preferentially priced drug. So pursuant to 4380, they need to keep in mind only 1% of the preferentially priced drugs can be sold to walk-in customers. So as I mentioned earlier, some pharmacies they're not all, they can service skilled nursing, they can service intermediate care facilities and residential. Some of these pharmacies also have walk-in patients where they have a retail side. And so if they have a retail side, a lot of these pharmacies that services skilled nursing facilities and residential care facilities will have two separate inventory to avoid exceeding that 1% walk-in. Next slide, please. Pharmacies that services skilled nursing facilities and intermediate care facilities, the facilities are allowed to have emergency kits, which is under Health and Safety Code 1261.5. It allows them to have 48 different drugs and 16 dosage in an emergency kit for oral drugs. If it's injectable, they can have an unlimited different types, but it's limited to 3 of the smallest dosage form or 1 multi-dose vial. So the challenge though with these emergency kit is trying to track them, restocking them, figuring out what dose was removed for which patient. And so again, with the use of the ADDS, this has really helped with the challenges of trying to do all of this. Next slide, please. Automated drug dispensing system. Currently, the board has 1,286 ADDS that are licensed, of which 810 are located in skilled nursing facilities. So as I mentioned earlier, these have been really helpful. The challenges here is if there's a change of ownership, change of location, or they move the location of the ADS, it needs to go through the application process again and the pre-license inspection. Issues related to the AUDSs includes monitoring for compliance and then reporting the medication errors to the board. Next slide, please. And then they have skilled nursing facilities and intermediate care facilities are required to have consultant pharmacists. Under Business and Professions Code 4072, the consultant pharmacist, if they're reviewing charts and want to make a medication change, they are allowed to, take an order and electronically transmit it to the pharmacy. One of the challenges here is that services for a consultant pharmacist cannot be provided at no cost or a nominal cost or below reasonable cost. Otherwise, it would be considered a rebate or a kickback. Next slide. And then finally, with drug take back, prior to 2017, skilled nursing facilities were allowed to take back unused and open medications that were left after a patient left the facility or was discontinued. However, in 2017, when the drug take back regulations went into effect, skilled nursing pharmacies no longer could take the drugs back. So as a result, these facilities can request the pharmacy to install a drug take back receptacle for the disposal of the unused drugs. They can either donate it to any of their unwanted and unused drugs as a donor to a repository and distribution program, or they can destroy it internally. If it's non-control, it could be done with a licensed nurse and a pharmacist. If it's or 2 nurses, and if it's controlled, it would be a registered nurse and a pharmacist to destroy the controlled drugs. Okay, and that is the end of my presentation.
Thank you, Janice. Really appreciate it. Members, do we have any questions or comments for Janice?
Hello, Dr. Dang. This is KK
Go ahead,
Kalikaya.
KK.
And I'd like to thank you for this presentation, as I'm coming from the long-term pharmacy world, and we have crossed paths in the past. I appreciate this presentation. As you know, long-term care does not get their own set of rules written for them as retail or hospitals do. So there are plenty of challenges, as you're aware. So appreciate the presentation. Thank you.
Thank you, KK. I was just saying at the beginning that it's a perfect timing for you to be joining this discussion and this committee. So thank you for joining this committee, KK. Claudia?
I just wanted to ask, it was mentioned that some of these drugs are destroyed on site. Can we just briefly talk about how that happens as protocol? Just curious.
Janice, you're muted. Sorry, I think you got 2 audio connections.
Okay, can you hear me?
Yes.
Yes.
Okay, so when a patient gets discharged or a medication gets discontinued, generally the nurses will take it out of the med cart if it's in a bubble cart, and they will give it to the director of nurses, and the director of nurses will lock it up. If it's a controlled drugs, the drugs get destroyed with the director of nurses, usually with the consultant pharmacist when they come in every month to do their review. If it's non-controlled, then the nursing staff themselves, 2 nurses, one destroys and one's a witness, and then they will document what was destroyed. So when they destroyed, how did they destroy it? They generally flush it down the hopper, which is not the ideal way of doing it. So with the drug take back, that facilities are now allowed, the pharmacies are now allowed to put in a drug take back receptacle. That's a better way of destroying it. The other way of like I mentioned, is they have the repository distribution programs that the skilled nursing facility can donate those drugs because they're if they're in bubble cards and they can demonstrate they have not been tampered with, those actually can be donated to this repository that the law allows, and then it gets redispensed to these county programs that do the redistribution. So there's 3 different ways of doing, destroying the drugs when it's at the facility. I would say the most common probably is in-house where they're destroying it. Um, we don't have very many facilities that actually have the drug take back receptacles installed at the skilled nursing facility. And then I don't know how many skilled nursing facilities are actually participating in the redistribution program.
Thank you. That helps a lot. So part of the destroying the drugs is flushing it down the toilet. Did I hear that correctly?
Yeah, when I was doing consulting, that was the primary method of destroying it.
And is there a way for us to potentially stop that? I mean, isn't that polluting our waterways to some extent?
I think that would have to fall under the California Department of Public Health because they regulate the skilled nursing facilities.
Oh, I see. Got it. Okay, so then we could recommend for them to add, like we were mentioning, like a take back program and have the kind of like the bin that you're talking about. Is that under our purview?
Yes, the drug take back receptacles are under our jurisdiction.
Okay, so we can make it more conscious effort to kind of increase that that process, or to incentivize them to do that instead.
Yeah, I mean, yes, we could do that.
Okay, thank you. That helps.
Thank you, Claudia. Any other member comments or questions for Janice? I particularly really appreciate this, Janice, because I have been trying to learn more about this topic and this practice. And your overview of the types of these facilities is excellent. And it is obviously a complex issue. So this discussion is going to go on for a long time, I think, in just this definition and how we're going to parse out all the requirements. Thank you, Janice. Please stay around. But before I let you go, well, you're not going anywhere. Don't leave, please. But we do have to open up for public comment. So we are going to go for public comment in WebEx. Tricia.
All right, if any member of the public would like to comment, please raise your hand by clicking on the hand icon next to your name, or if you've called in, pressing *3. We are displaying instructions and we'll give you a moment. All right, I see no requests for comment. I return the floor back to you.
Thank you. Thank you, Tricia. Thank you, Janice. Please stay around because we're going to have questions for you for sure. But, well, if you have to go, we understand. I think that this is going to be a lot of deep discussion, not just this committee meeting, but probably a couple more meetings to come as it gets really complicated and very legally confusing and questionable. So members, we're bringing back this discussion to you guys now. I'm hopeful these presentations have provided some education. And as we transition to our further discussion on this topic, you'll note that the meeting materials include some draft definitions to assist the committee in its discussion. I have reviewed the draft definitions, and believe they are an appropriate starting place for our discussion. This is where I really need your help and public's input as well. I noticed that mail order pharmacy, we probably need to add the percentage as an annual basis. Also probably need to figure out if we need to distinguish a resident mail order versus a non-resident mail order pharmacy. I would imagine non-resident pharmacy would automatically fall into mail order pharmacy. So as I open up for member discussion, I really appreciate your comments on the various proposed definitions and would also appreciate your feedback if you believe additional pharmacy models should be included in our discussion. As an example, do we need to define a nuclear pharmacy? I do really need your help on this. Understanding that this is just a starting point. At this moment, how I envision this to be, as I said something a little bit during Dr. Martinez's presentation, is we will not change the license category, and most licenses will remain as PHY license types. But what will be added as our statutory proposal would include all these definitions of pharmacy business models. And then in the statute would allow an explicit language allowing, now this is where I need your help with the Corinne. Corinne's help is needed. I don't believe a statute could allow the board to override a statutory requirement. So this is where things are going to get a little tricky. So at least some things could be exempted out via regulation. Is probably, that's a step. But for example, for consultation, I would imagine during regulatory development, we would say this regulation would not be applicable to quote unquote closed door pharmacy or something along the lines. Another example would be for labeling requirement. Whatever the statutory definition of infusion pharmacy would not have to adhere to our patient center, patient center label regulation, unless they're dispensed to outpatient pharmacy or something along the lines. This is going to get really messy and tricky easily, so we all have to kind of keep that in mind. So before I go on any further, I just want to kind of survey members to see your thoughts on how to proceed, and maybe Corinne, if you want to chime in on how we might make this work. Sorry to put you on the spot.
Hi, this is Corinne. So, yeah, I mean, I think the approach that you outlined would be, first decide on what definitions you want and, define those. And then, like you said, an exemption-based approach where you would probably, whatever regulation you're looking at, you would determine, pharmacies that meet these definitions this regulation wouldn't apply to them. I'm not
Got
sure
it.
that totally
That-
understood your question. So if
No,
that didn't answer
that
it,
you exactly addressed it. However, the part that I am curious is the statutory requirement that we have in our law. So anything that's in the Business and Professions Code, the board cannot obviously override those statutes. So anytime we would like to change anything to exempt out any requirement in the statute in Business and Professions Code, we would not be able to do that on our own, correct? So that's when things get, I think, really tricky.
So, Sung, this is Anne. Sorry to be jumping in. I'm not an attorney.
Oh,
Don't play one on
hi.
TV, but I'm just going to throw
Anne
out
plays
my thoughts. I think
played a great.
honestly, Sung, it's
Uh-huh.
going to depend. It's going to depend on the statutory language and then looking at it through the lens of our regulation and our regulation authority. So I don't know that we can give you an easy answer. I think it's going to depend on what the specific statute states and where there's authority. So I don't know
Right.
that we can answer that question for you at
figured.
this
Got
moment in
it.
time.
Yes, got it. That's where things get tricky because I'm curious if the statute can actually say, unless the board can waive via regulation these requirements or something along the lines, if that's possible. I'm not a legislator. I'm not an
Yeah.
attorney, so I don't know.
I think, Sung, it's really going to depend on the language of the statute.
Got it.
and
Okay.
this is Corinne, and that was a great answer, very lawyerly answer to say it depends.
Oh, I know. Anne is Anne's a better attorney than many ones in TV and the real ones. So I appreciate Anne. Okay, members, any thoughts before we proceed on to this discussions? I do need your help on some of the draft definitions and where we're going with this. So Renee, go ahead.
Hi, yeah, thank you. I'm so glad we're having this discussion. And the presentations are excellent, so thank you for the background on those. So in looking at the definitions, I think I only have feedback really on one, but it's just kind of minor. I just on specialty pharmacy. So I'd be curious to, when we have comment, if there's other feedback about the definitions, but I felt that the specialty pharmacy one seemed a little different than the others, and a little awkward. So I just have a suggestion of just a more simplified. I think it's there's kind of some adjectives in there that I feel like makes it sort of qualify, whereas other ones don't have anything like that. Like close, serious conditions, close monitoring, extensive support. And then the phrase to ensure good health outcomes. I mean, I think you could add that to every single pharmacy.
Right.
So
exactly right. Yes.
my suggestion, just to simplify it, although I would put, so my suggestion was specialty pharmacy is a pharmacy that provides high-cost medications for complex conditions which require special handling, monitoring, and patient support.
Okay, let's go with that.
Again, just,
and I know the definition of specialty pharmacy is extremely controversial. So I know that that's very tricky because it's, again, that's why we just put it out there.
Right.
Anybody and everybody can call themselves a specialty pharmacy, right? And so that's when things get very complicated. And so lots to do with the PBMs and the payers and the Medicare Part D and so many layers. So, but I think we'll just start there. Okay.
Thanks.
Thank you, Renee. KK.
Good morning. Thank you for that presentation again. My question is for, a lot of these pharmacies have overlapping practice. For example, closed door pharmacy is not necessarily closed door. There are a few retail patients who still go to a quote unquote closed door pharmacy and pick up their medications as well. There are closed door pharmacy who do the back end work or front end work for the other pharmacy, which is also a closed door pharmacy, but not open 24 hours. So they become their central fill pharmacy, if you call it, or a backup pharmacy, if you call it. So there is a lot of overlapping of ideas. So I think maybe we can have an inclusive language that say this is the principal activity of majority activity of this pharmacy, and it doesn't become mutually exclusive terms, because there is a lot of overlap in many of these things that is happening here,
Exactly.
because they
And
have the
that,
retail license.
and KK, your point is exactly why I have been very hesitant to bring this up for a long time, because it gets extremely complicated. But I do think that there's a value in this to proceed in some fashion. So that's why on our meeting material, it does say pharmacy could fall within more than one of the, there's a typo in the meeting material, sorry, one of the proposed definitions depending on their business operations and customer base. And I think that to also address your comment, we would do it in ways where these business models would probably be a reportable requirement to the board on like an annual basis, just to keep up with what the business models are. Because currently it's not a requirement. I think it's an optional and it's captured during the application of the pharmacy. But then things change. If you change your business model, then it goes, we don't actually know what they do, because it's just one license type. So many layers. Anyway, KK, go ahead. Yeah.
Is PIC's self-assessment could be one of the routes through which we say, what activities are you doing in this pharmacy? And maybe a question can be created there and say, what percentage of activity, mail order or infusion, or when there is an overlapping activities happening. Could that be a possibility?
Right. Sure, that's a possibility. Yeah. I mean, again, this is a very early language, early on, so I think anything is hopefully possible. So, all right, good thoughts. And I think we're gonna have to figure out how to be more of how do we handle situations where a closed door pharmacy is not really, so we need to probably add more percentage, or like how we added in the mail order pharmacy world. That gets, a little tricky, and what percentage of what, right? So dosages, prescriptions, number of patients, all that gets extremely tricky. Satinder.
So I think you, Dr. I think you mentioned this already. In mail order pharmacy, the 70% total, I think you had mentioned maybe annual. And my question would be, maybe that's missing. And also, is it self-reported or would it be audited? And how does that work? Like, how do we determine that? That's maybe need to be included. And then the online pharmacy just seems like it's kind of vague. Maybe, like e-commerce, telepharmacy, is it regular pharmacy? I mean, like, how does that's the other that came to mind in terms of definitions for me.
Right. Like we might need to add a word like only through digital channel or something. I think that this is an attempt at us trying to understand the marketplace out there for the pharmacies that are really just kind of online, like, those that people don't even have any way to get to these businesses because they're just on the app, and they're like a contracted provider to, like certain medications, the GLP-1s and so on. So there's just no real good understanding of those businesses. So it's an attempt at trying to have more understanding of those businesses. I think the part that I am curious to get some thoughts is how do we, I guess, make this into a practical model for pharmacies to follow. So I think KK, your thoughts more is a self-determination, maybe an annual or biannual determination by the PICs, and to figure out self-determination of what rules and regulations they must follow. That seems to be your perspective. I'm in between because I think it gets a little hard for us to enforce if things do go a little sideways. So how do we make sure that people know what they're doing and all that? So I guess that will be depending on how the statutory language comes about. I think that self-determination is probably a good place to start. And then how can we make sure that pharmacies are actually doing what they're supposed to be doing? Because I think that gets really complicated in terms of enforcement. I determined it last year as infusion center pharmacy, but we started to dispense this starting, this year, and, I'm no longer, so I don't want to follow this rule, whatever. It just gets really tricky here. So I do need a little help. KK, your hand is raised, so I'm sure you have some thoughts on that.
Yeah, and in my practice, we come across that on a daily basis because if it's a long-term care pharmacy or a closed-door pharmacy, by this definition, there's a one set of rules for the skilled nursing patient, the other set of rules for the ALF patients, and pharmacists, technicians, they all use their discretion about what is a valid prescription, and then it's really a huge human resource is used to determine what prescription is good and not, and a lot of time is spent in taking the verbal prescription, as Ms. Dang mentioned in her presentation. Take that verbal, follow up with the doctor in prescriber in 7 days and make sure it's compliant. If it's not compliant, then report that to DEA. And it's really a large undertaking, very labor intensive. So that discretion is happening, and if somehow we can reduce that burden on pharmacies, especially the ones that are juggling between a nursing home patient and an ALF patient and a retail patient and a jailed inmate and the ICF and an MHRC and crisis centers, all of that creates such a plethora of net that people fall into that. So if anything, by definition, facilitate the ease of business or ease of doing business, because ultimately what it does is slows down the process and increases the distance between the patient and the drug. And in the skilled nursing business, you have to provide medication within 4 hours, as you know, and the classification of drugs, as Ms. Dang also mentioned, antibiotic, antiemetics, painkillers, and anxiolytics, sedative hypnotics. Ultimately, this, for the lack of better term, bureaucratic process increases the time it takes for pharmacy to go from order entry to label. And then, don't forget, for this kind of pharmacies, there's also a drive time for hour, 2 hour, 3 hour, one way sometimes. So it really increases the patient's availability of medication at the time of need. So that if we can solve for that, or at least make it easier by somehow defining something, I think that'll be great.
Got it. Yes, agreed. Absolutely. And I would remiss to say that I think outpatient pharmacy is used throughout our law, so we probably need to add that to our definition, which it is alluded in the meeting materials, which is we interpret it as to mean pharmacies that provide medications to consumers outside of an inpatient setting. And so it is very broad. So community pharmacy and outpatient pharmacy is not really interchangeable, but it is interchangeable. So we probably need to figure that out as well. And so from our discussion so far, we have needing to figure out a language. So what to do if a business does, close their pharmacy who may not be closed 100%. How do we do, some of the percentage adjustments and specifying what the percentage of what? An online pharmacy language, specialty pharmacy language. And Satinder, go ahead.
No, the only thing I was going to point out was that the community pharmacy,
Yeah.
as it's described in here, like we have a chain definition, 75 and more, same owner, and we have an independent pharmacy, 4 and less, and then you have this whole between 4 and 75. That, like, community, like, does that need to be, how do we incorporate that, or does it make? I don't think that would make any difference. Independent pharmacy, community pharmacy, they're all
Right.
same.
Yeah. And I believe that's a great point because I believe only thing that's relevant for that 4 or less or 4 or more was the no 4 or less is the because I think it's more than 4 was with the staffing statute that it got inserted back in 2017 exempting out, I believe that, and that was what the purpose was, that, but also I could be wrong. So again, this is where it gets really complicated. I would hope that during the statutory proposal, we would clean out that and really kind of reevaluate the purpose and intent of all those in our own definition to streamline and clean all that up would be the hope, right? So that we could figure out and make sure, the target and the intent of the legislatures throughout the years that got built upon, right? I know there's a lot of statutes just separating for this chain community pharmacies and exempting out, like, the correctional pharmacies are exempted out in many ways. So we may need to add correctional pharmacies into our definitions. So it's just, yeah, long discussion, lots to come, but I think this is very helpful for your inputs. I think that overall, this is a helpful thing so that our very complex pharmacy law can be simplified. The intent obviously is to simplify so that our patients can be, we don't want our businesses to focus on, I don't want to use the word bureaucratic. I just want our businesses to be able to provide the best care possible to our patients without as much as, what is really minimally necessary versus, right, the gotchas and the little things that I think are not serving any purposes for them to really, like, my thing was, I don't want it to just be a check mark on a box just for what purpose, right? We want people to be able to provide care for patients in the best manner possible. So that's the intent of it. That's why we're doing this. And I'm hoping that this is going to land somewhere in really providing our pharmacies, who are, I know, very strained and constrained and challenged, to be able to provide care, the best care possible to our patients. So that's the goal and intent. And I'm hoping that we land somewhere moving forward. Members, before we go to public comment, any other comments and any other suggestions? Hopefully with this, we'll have something for the full board, updating some of our things, but also probably statutory proposal won't come about until maybe the next meeting at the earliest, but if not, maybe the meeting after, but we'll obviously keep this posted. It's gonna be a long-term agenda item. Members? Okay, then we're ready for public comment. And do we have anybody in Sacramento?
No one in Sacramento.
Thank you. We're ready for public comment. Trisha?
All right, if any member of the public would like to comment, please raise your hand by clicking on the hand icon next to your name, or if you've called in, pressing *3. We are displaying instructions and we'll give you a moment. All right, I see no request for comment. I return the floor back to you.
Oh my God, I'm surprised. Is that function working? Oh my God, we do have a late hand, I think. Dr. Kim?
Thank you. Yes. All right. Dr. Kim, you should be able to speak. So Sean Kim, we'll try that one more time. Did you have a comment?
Maybe
Hey,
not.
can you hear me?
Oh, there he is.
Yes, we can.
So sorry. Happy New Year. Good morning, everyone. My name is Sean Kim from California Pharmacists Association. I really appreciate the conversation around different types of pharmacy. And as you know, there's a lot of different interpretations depending who you talk to about like specialty pharmacies or whatnot. One thing that I also wanted to point it out is that as the pharmacy practice evolves, there is a need of some clarification to how to define the kiosk models as well. It is ongoing, especially in Los Angeles area. So it depends on how we approach with the duty to consult, or is the telemedicine is really enough for every people that who are picking up the medicine from the kiosk for the safety needs of the consumers. So that's one thing that I wanted to point it out, but I'm looking forward to have more conversation to other items. Thank you.
Thank you, Dr. Kim.
All right, I see no further raised hands. I return the floor back to you.
Thank you, Tricia. That's actually a good point from Dr. Kim. I think the kiosk right now is just a extension of the PHY in a certain medical office building. They can be in there, and I think one PHY, I don't know if Janice is still on, but one PHY can have up to, I think, 20 or 25 APDS, but they must be located in where the patients are receiving care. So anyway, that may be another addition to our pharmacy, as we already have remote dispensing site pharmacy, which is not the same as what Dr. Kim is probably alluding to, which is the kiosk pharmacy. So again, very complicated issue. Lots more to come. So it's 10:45. We should take a break because we have a few more things to go through that are a little bit longer. Then it's going to take more than probably 30 to 45 minutes. So we will take a break and we'll come back at 11 a.m. Everybody, I have to come back at 11:01. I think it has to be 15 minutes. So we might have to come back at 11:01. I'm sorry, 11:01. Okay, it's exactly 11:01, so we're gonna get back on it. Just confirming everyone's back. I think here, Satinder, are you back? I see you.
Here.
Thank you, Satinder. Renee.
Present.
Thank you, Renee. KK.
I'm here.
Thank you, KK. And Claudia.
Present.
Thank you, Claudia. Welcome back, everyone. Next agenda item is agenda item 5, discussion of pharmacy practice experience requirements pursuant to Business and Professions Code Section 4209, including possible action to make a recommendation to the board to remove potential barriers to earning experiential training outside of ACPE accreditation requirements and consider a draft policy statement. Today, we also continue our discussion on the pharmacy practice experience requirements. The meeting materials provide background information, including pharmacy law requirements that establish a requirement for an intern pharmacist to complete 1,500 hours of pharmacy practice experience before applying to take the pharmacist licensure examination. The statute further provides that an applicant that has graduated after January 1st, 2026 from an accredited college of pharmacy is deemed to have satisfied the pharmacy practice experience requirement. The meeting materials include the provisions in Business and Professions Code Section 4114 that provide that a pharmacist may not supervise more than 2 intern pharmacists at one time. The meeting materials also include background information from our prior discussion, including information on the updated ACPE standards that all accredited pharmacy school programs must satisfy. This includes completion of introductory and advanced pharmacy practice experience. The standards establish rotation requirements that require completion of a total of 1,740 hours of experience. As a quick reminder, the committee initiated this discussion in response to comments suggesting that the board should re-establish a requirement for an intern to complete internship hours outside of the practice experience gained as part of their pharmacy education. During our October 2025 committee meeting, we received 3 presentations. Brief summaries of these presentations are included in the meeting materials. The presentation slides and live stream recording of the presentation is included as part of this meeting material posted on the board's website. As you recall from our discussions during the committee and board meeting, it was decided that the board should not take any action at this time to update or propose the current legal requirements for intern experience, but rather focus on an approach that encourage, albeit strongly, intern pharmacists to gain experience outside of the experiential training gained through pharmacy education. I draw your attention to attachment 2, which includes a draft policy statement that could be used to memorialize the board's position on the importance of earning such experience. I believe that draft statement strikes a good balance, keeping it simple, focusing messaging on both intern pharmacists as well as employers. Members, I welcome your thoughts. Any changes that you would like to see, please share. Satinder, Dr. Sandhu?
Dr. I 100% agree. I think from our discussions, there were a lot of concerns about making additional requirements. So I think this, the board policy statement expressing the supports for interns to obtain additional experience, which we identified, and I have talked to some interns as well, took their input, and they feel like that would be helpful, but not add additional requirements which could have negative consequences in terms of them obtaining, especially in rural areas and so on, and be able to get intern positions. So I think this statement, I totally agree with this policy statement, striking that balance.
Okay, perfect. Thank you, Dr. Sandhu. I take your silence as an agreement for the rest of the members if I don't hear. Agreement, okay. Perfect. Then this is a good policy proposal that we can bring it to the full board for discussion. Now, as I mentioned, as part of my initial comments introducing the agenda item today, pharmacy law established a pharmacist to intern pharmacist ratio. I believe there may be an opportunity to expand flexibility to increase perhaps to a 1-to-3, perhaps determined by the PIC in all settings. Maybe so that is a barrier that may exist currently. So I do not believe whatever the ratio cannot be feasible in all pharmacies. So there are many pharmacies where this increase can be possible, but then there are pharmacies maybe not. So it should be maybe determined by the PIC for the ratio. So if we do agree on this concept, it may be appropriate to improve access to intern pharmacist positions without compromising consumer protection. So members, what are your thoughts on this? I suggest that I work with staff to discuss maybe potential statutory language. And if this is something that the committee agrees, we may even be able to bring this to the board, a statutory language, because we have a meeting in about 3 weeks. So, and may be able to sneak in, and I'm sorry not to put pressure, but if we can sneak in by January meeting, we may be able to get this through this year in a very unlikely chance, but it's probably non-controversial, hopefully. So members, what are your thoughts on that? Striking out the ratio or determined by the PIC on intern pharmacist? Renee?
Yeah, I think I would definitely support determined by the PIC. I think, we've been through a lot of discussion about ratios and there's so much variability. So I think, the kind of the standard of care approach, PIC determining for the location, I think that seems like the best balance for intern employment.
Sounds good. Dr. Sandhu?
I agree with the striking up the ratio and then allowing the PIC consistent with the technicians. And I think in this case, even not even having the number, just allow the PIC. yeah, just allow PAC to determine based on their practice.
Sounds good. Yes, I would imagine some settings like mail order pharmacies can,
Yeah.
you know, many different
Accommodate more.
variables. Yeah. Okay. KK Claudia, okay to proceed? Agreeing? Disagreeing?
I'm okay with the PIC determination. I think that makes
Sounds
more
good.
sense.
Perfect. Claudia?
I'm okay too. I just wanted to clarify. So you mentioned like the mail order pharmacies, they don't need to have these roles in place because they're just shipping. That's kind of like the
Oh
logic.
no, they do. Claudia, for sure, they have to follow.
Right.
Yeah, they definitely have to follow, but it's just the volume and the business operations are very different. There are a lot of office space, right? And so just very different kind of environment. And so PIC could be managing 5,000, well, maybe not 5,000 people, but like 200 people, 300 people, versus a pharmacy's managing like 7, could be 1, could be 2. It's just really all over the place. And I think we're looking more at, ways to, again, encourage, remove barriers so that a pharmacy who wants to employ interns are not hindered by having ability to hire interns because of the ratio.
That's right. That's right. Okay. All right. Thank you.
All right. Okay. Sounds good. I'm guessing we're ready for public comment then. Moderator?
All right, if anyone would like to make a comment, please raise your hand by clicking on the hand icon next to your name, or if you've called in, pressing *3. We are displaying instructions and we'll give you a moment. And I see we already have some raised hands, so Kyle Souza, you should be able to unmute.
Good morning and happy New Year, everyone. My name is Kyle Souza, and I'm the Dean at Loma Linda University School of Pharmacy. I really appreciate the board's effort on this front. My simple concern with the current draft is actually not with the intent, which I support, but just rather a simple modification in its framing. I raised this point because it's listed in the meeting attachments as a policy. And because once something's labeled as a policy, it can inevitably shape expectations or enforcement, even if that isn't the goal. And so for that reason, I would simply recommend that perhaps it be considered that it be reframed or relabeled as guidance or as a support statement. And thank you for the opportunity to provide public comment.
Thank you, Dr. Souza.
All right, and next we have Dr. Sean Kim. You should be able to unmute.
Good morning, board. My name is Sean Kim, speaking on behalf of CPHA. CPHA supports board's draft statement. Also agree with Dr. Souza's last comments about policy versus guidance. We also recognize the pharmacy intern hours earned outside of experiential learning will be helpful, which also brings the real world practice. Allowing qualified work experience counted as an experiential learning hour is great, but also we have talked about a few concerns from the last meeting. Tracking qualified hours or reporting process has to be clarified, so we're not adding much administrative burden on to the preceptors as well as the students. And as noted, that in addition, CPHA also encouraged the boards to consider incentives for the preceptors. Not only the employers and the intern pharmacists, such as continuing education credits or tax exemptions or licensure fee discount could be considered. Preceptorship is the essential part of the mentorship, and which is the method of layer learning, which aligns with the ACP's evolving continuing professional development model, CPD. So we support sustain the preceptor engagement. We encourage the board to clearly affirm that the hours are complementary, not duplicative to the current experiential learning. Thank you again for letting me have an opportunity to comment.
Thank you for the comments, Dr. Kim.
All right, this is a moderator. I see no further requests for comment. I return the floor back to you.
Thank you. I'm gonna go to you, KK, but before, can I just have Ann, can you just speak one thing about The policy statement versus guidance, I think that may deserve a little bit of an explanation for the board standpoint. I respectfully, I think that for our board, the way that we function, I don't think that it would make any difference, to be honest with you. It's just a thought of the board and that we're just hoping to provide more encouragement. Anne? Sorry to put you on the spot again.
Dr.
My
O, this is,
attorney.
yeah, this is Corinne. Can you hear me?
Yes, Corinne?
Yeah, so I mean, I'm happy to just chime in to say calling it a policy statement has no effect on whether, it doesn't give it the force of law. If that clarifies anything.
Thank you. Thank you, Corinne.
Yeah, if I can just also, thank you, Corinne. Historically, the board has used the policy statement to convey things even like, tobacco or those kinds of things, right? So I think that policy statements is typically how would be consistent with the board's past practice. And then just do want to highlight that the board guidance generally, the board does not release like guidance statements. And
Yep.
I guess potential concern that there could be confusion because the FDA does routinely issue guidance documents, and that might create a little bit of confusion. Just throwing that out.
Thank you. Thank you. KK. Dr. Jha? Sorry. KK is disappeared from my screen. Maybe connection issue. While we wait for KK to hopefully return to the abyss of the technical difficulties where we're all facing these days, it seems like. I would like to also say that we're going to try our best to see if there's other incentives that we can come up with for preceptors. I do think it's a good point, but again, remember we are a consumer protection agency and our government agency gets really tricky and difficult. So we just have to be mindful of all of that. We'll do our best, but I think that this is as far as we can go in terms of incentivizing and encouraging internship experiences. So I appreciate the comments though from the public. Give KK a little bit of time. I know that legally she has to be visible. Are we all not seeing KK on screen? Is that just me?
We do not see him either in the room.
Okay. Well, I think that there's no motion. So we will just reserve him to be able to speak freely on this issue at a later agenda, as the time is very of essence. We got to move forward. So we're moving on. Members, any comments before we proceed? We're ready to move on to agenda item 6. Discussion of changes in pharmacy law included in Assembly Bill 1503, Berman, Chapter 196, Statutes of 2025, including updates on implementation activities. Transitioning to the next agenda item, which is an update on implementation activities related to Assembly Bill 1503 that were previously identified and discussed. I have a feeling this will be a standing agenda item for the rest of 2026, as many implementation activities are ongoing. As a brief reminder, Governor Newsom signed a board sunset measure Assembly Bill 1503 on October 1st, 2025. With this action, significant changes to pharmacy law became effective January 1st of 2026. As I stated during our prior discussion, I'm so proud of the board's effort to pursue so many important patient safety provisions. The board's legislative report and final outcome on the measure reflect the board's strong commitment to California consumers. I'm very proud to be a member of this board and to work with such dedicated to consumer protection California patients and licensees. The meeting materials reflect implementation activities undertaken since the November board meeting. From a process standpoint, I do not plan to review each area separately as the meeting materials were released well in advance of our meeting today. I will note that the board will be releasing a newsletter specifically discussing the changes made in AB 1503. I have reviewed a draft and anticipate the newsletter will be released early next week. In addition, the board posted the statutory changes for 2026 on its website. and the board's webinar describing legal changes for 2026 should be available by the end of this month. Separately, the Enforcement and Compounding Committee is beginning its review of updates to the various self-assessment forms. I would anticipate an update on the committee's work. We have an update on the committee's work, but we will have an update at the full board meeting for the update we have worked on yesterday at the committee. We're hopeful that the board will release our also ethics webinar that incorporates some elements of standard of care into our webinar sometime this month as well. All right, members, I will quickly provide my comments on our various items that are laid out and will provide each of you with the opportunity to comment. Some of them I might clump together, so just bear with me. So first, beginning with the Pharmacy Technician Advisory Committee, as reflected in the meeting materials, Dr. Satinder Sandhu has graciously agreed to be appointed and to serve as the board member on the advisory committee. Satinder, thank you for volunteering to serve in this role. I believe by de facto of how the board functions, you'll be a chair of this advisory committee. So please correct me, Corinne or Anne, if that's not correct, but I think that seems to be the most logical way. In addition, I have reviewed the draft updates to the board member procedure manual. Updates to the manual will be considered by the full board during the January 2026 meeting. I'm hopeful we'll have the application process available in advance of the April board meeting. Members, do you have any comments or questions on the implementation activities related to the advisory committee or PTAC or PTAC? Friendly reminder, upon further review, it was determined by legal that members would be serving in full volunteer capacity with travel reimbursement as needed. Members? I think just want to reflect that KK is still not back. I don't see him, so he may be having technical challenges. So next, implementation activities relating to the retitling to advanced pharmacist practitioners are underway. As noted in the meeting material, Section 100 regulation materials were prepared and are undergoing review by DCA prior to submission to the Office of Administrative Law, OAL. Identified applicants and instructions have been updated and posted the first of the year. Any other comments on this, members? We're moving quite quickly, so please raise your hand or unmute if you have any comments. Moving to the provisions updating the definition of pharmacist following this statutory amendment, which clarifies that the pharmacists are not restricted to practicing only within the four walls of pharmacy. You may recall that the board voted to initiate a rulemaking to establish parameters for remote processing in the community outpatient setting. Here goes another definition. Since that time, staff have prepared the rulemaking materials. Necessary pre-reviews were completed and the rulemaking file was submitted to the Office of Administrative Law for publication. It is my understanding the 45-day comment period will begin later this month and the board should be positioned to consider comments during the March 2026 board meeting. I would like to thank everyone that worked so diligently and timely to expedite the completion and review of this draft regulation proposal that is long overdue. Members, do you have any comments or questions on the implementation activities? All right, moving on. As I previously mentioned, consideration of revised self-assessment forms is being handled by the Enforcement and Compounding Committee. Additional implementation activities require the board to complete a Section 100 regulation change. As included in the meeting materials, staff have prepared the materials, which are currently undergoing review by DCA prior to filing with the Office of Administrative Law. Members, any comments? Friendly reminder that a lot of the regulations are struck down and new form and format will be forthcoming once the full board approves and is going to start in the Enforcement and Compounding Committee for those forms. All right, members, transitioning implementation activities related to the standard of care practice model. You'll note that the board's policy statement has been posted on the board's website and conforming changes made to the board member procedural manual. Board trainings related to HIV PEP and PrEP as well as naloxone have been removed as trainings are no longer required by law. Further, Section 100 changes have been prepared and are undergoing review by DCA prior to filing with the Office of Administrative Law. All right, members, moving to the transition to FAQs related to digitizing records. You'll note that the draft FAQ is not yet available. I am hopeful staff will have a draft ready for review and consideration for our next meeting. As part of FAQ cleanup, I'm hopeful we can also have a consistent landing page for FAQs and same format for all FAQ documents and have easy access and compilation of these documents to be completed sometime in 2026 for all FAQs. Members, any comments? Zooming through. Oh, there's KK name popped up, so hopefully he's back. Hi, KK.
My apologies.
No worries.
My computer decided to have a software update and restarted. And I was having trouble with my personal computer not joining WebEx, so I had to use the work laptop. My apologies.
No worries. We're all at the mercy of these laptops and computers and ITs and technologies. KK, sorry, I know we were zooming through our next agenda item, but I know your hand was raised. So out of the respect for you, I would like to make sure that you are able to say a piece about the previous agenda item 5 really quick, if you would like to add anything.
I was actually raising hand to let you know that my laptop is about to quit anytime.
Ah, that makes sense. Sorry, did not get to you fast enough for that. Okay, so then we're now on agenda item 6. We're zooming through quite a few listed on our meeting materials. Next is, as we move to implementation activities related to non-resident pharmacies, I would like to highlight that many of the relevant provisions do not become effective until July 1st of 2026. And as the meeting materials highlight, additional dates for the CPJE were added. In addition, outreach to non-resident pharmacies regarding changes has occurred both through the board subscriber alert system as well as directly via email to facilities that have an email address on file with the board. It is my understanding additional reminder communications will be sent over the coming months as board staff monitors implementation. In addition, you will note that the board's policy statement related to the role of the PIC was posted. Conforming changes to the board member procedural manual will also be reviewed by the board during the January 2026 board meeting. It is important to remind our non-resident pharmacy colleagues, licensure is the first step, and then there is also a need to apply to be a PIC and the training course you must take prior to applying to be a PIC in California. Also, I know that PIC policy statement combines 2 elements, one related to non-resident pharmacies and one related to just the PIC. So hopefully you can, our PIC policy statement, that would convey the board's thinking on that. Members, any comments related to those? Or anything actually for the matter, since we're zooming through so many topics. But again, these are just updates, not a rehashing of what we've discussed already. Okay, moving next to pharmacists in charge and staffing. As I just stated, the board's policy statement has been updated. In addition, another FAQs related to staffing have been updated and posted on the board's website. Do you have any comments or questions? So I was just saying that there will be some easier compilation for all FAQs for licensees. Probably live under for licensees page in our website and have a dedicated page. Well, we do have a dedicated page for FAQs, but it will be sure to be compiled in that page. So that it's not all over the place with all topics, and maybe some topics it's good to be combined. So we'll more to come on that. Next is transitioning to notice requirement for chain community pharmacies. You'll note that the Communication and Public Education Committee in about 3 hours will be considering a draft notice later today. And next 4 areas altogether, I note that related FAQs have been updated and posted to reflect the clarifying changes made for specially trained pharmacy technicians. In addition, the retired pharmacist license application has been updated to incorporate the new pathway to restore a retired pharmacist license. There are no updates related to implementation of the new fine authority for mail order pharmacies. I also note that the staff have developed processes to waive fees for a new pharmacy that opens and provides in-person patient care services in medically underserved areas. And on this topic, I would imagine anyone who is already in this definition, can we do outreach or at least a reminder possibly so that they may, I know not everybody's always looking at what we're doing. So I would like for our licensees who may be doing this already are notified that they may qualify as this distinction. So are we able to do that, Anne?
So Sung, I think that what we need to highlight is that this is a new requirement. It's not applied retroactively.
Oh, so for a pharmacy, during the renewal though process, they can be waived, correct? The renewal fee can be waived during the renewal process, correct?
Yes.
Okay. So, alrighty, I'm sure that this will be included in as part of the like a renewal application notice to the pharmacies who may be in the medically underserved areas. Okay, members, any comments on to any of these topics or anything that we've discussed that we zoomed through? Claudia?
For the pharmacies in the rural areas, is there like a map that we're going to use internally to determine what those areas are, or who's providing that guidance?
Ms. Sodergren?
Yeah, so staff are identifying through the use, we have a geo search function, and so we're using that as the way to try to identify. And then we're working on the technology piece to flag those records.
So that somebody applying wouldn't be able to self-identify if they would qualify. We have to do the vetting ourselves and then give them notice if yes or no.
Yeah, so as part of our process, we do the geo searching for a variety of different reasons. So we are already performing that function. So we're just adding that as one of the criteria that we're looking at as part of the application process.
All right, thank you.
Claudia, just to plug in our staff's efforts also that they have built this pharmacy locator on our board's website. It incorporates it incorporates all PHY license types on a map. So you put your zip code, you can see all the pharmacies in that zip code, and you can like move the map. Very useful, and I'm sure that can be utilized to help this process, but also it's really good for consumers in looking for pharmacies. Obviously, it does not contain data elements that we are not required to keep, which is what kind of business models, which is why we're discussing that at the earlier part, right? Because it's all pharmacies that are licensed as PHYs is on that map. But,
that's right.
One step at a time, we can't all do everything all at once. We're not magicians.
No, but this helps. Thank you.
Thank you, Claudia. All right, members, any other comments on agenda item 6 related to AB 1503? We'll keep you all posted on implementation activities, and before we will open up for public comment. I'm assuming there's still nobody in Sacramento, so we'll go to WebEx.
All right, if anyone would like to comment, please click on the hand icon next to your name, or if you've called in, press *3. We are displaying instructions and we'll give you a moment. All right, and Dr. Kim has her hand, so Dr. Sean Kim, you should be able to speak.
Good morning again, board. Sean Kim on behalf of CPHA. CPHA appreciate the board's ongoing work to implement Assembly Bill 1503. It was a great win and supports the discussion and reflection today's committee's report. We support the clarification of AB 1503, retitle Advanced Practice Pharmacist to Advanced Pharmacist Practitioner, which helps consistency and clarity in licensure terminology. However, there are some confusions still remaining regarding abbreviation. I know it's a small thing, but it'll be good to be communicated through the public between APP versus APH. Some people start using different abbreviations, so it'd be good to clarify. We also appreciate the inclusion of the draft statutory language clarifying the advanced pharmacist practitioner license is dependent on the active underlying pharmacist license, and the advanced license would be canceled by operational law if the pharmacist license is not renewed. This clarification promotes regulatory consistency and avoids the unintended licensure ambiguity. Finally, we welcome the board's consideration of the retired advanced pharmacist practitioner license pathway, given the complexity
Sorry,
of...
Dr. Kim, do you might want to comment that on the next agenda item? Might be
Yes, I
sorry.
apologize. Yeah, I was getting my head too ahead. Apologize. Thank you.
No worries. Thank you, Dr. Kim. And just for the record, we are unable at this point to change the abbreviation in our license on our website at this moment, and can confirm, please, but that I think due to many reasons that's not possible. But
yeah, as previously indicated, the prefix for the advanced pharmacist practice licenses or advanced practitioner, yes, is not changing.
Thank you so much. But it's just prefix. It's just the prefix. The title is Advanced Pharmacist Practitioners. Any other comments, Rajan?
I see no further requests, so I return the floor back to you.
Thank you so much. Okay, we are ready to move on to our next, almost last agenda item 7, discussion of statutory proposal to establish provisions for a retired advanced pharmacist practitioner license and clarify provisions regarding cancellation of an advanced pharmacist practitioner license. Today, we have the opportunity to consider a statutory proposal to establish provisions for a retired advanced pharmacist practitioner license that would also clarify provisions related to cancellation of such license. Given legislative deadlines, should the committee and board agree, I'm hopeful the board will be positioned to sponsor legislation this year. Attachment 3 includes a draft proposal. It seems really long, but it's just have a lot of technical elements included in it. Just look at the underlines is what we gotta look at, and the addition of one element, which is section 4212. So you'll note that the proposal would add new section 4212, which would establish provisions for an advanced pharmacist practitioner to request a retired license under specified conditions, including that the license has not been revoked. The approach offered mirrors the recently implemented retired pharmacist license provisions. In addition, the proposal amends BPC section 4402 to clarify that an advanced pharmacist practitioner license is canceled when the underlying pharmacist license is not renewed or a retired pharmacist license is issued. I support this proposal, and I think it's consistent with what our intention is for our original proposal in AB 1503. So I note that the proposed changes in 4402 align with the definition of an advanced pharmacist practitioner as an individual that is, among other items, licensed as a pharmacist. Members, your thoughts on this? If you are in agreement, no action is required. So, Satinder, go ahead.
So I assume that, I think makes sense that if one is canceled, the other one would be canceled automatically. Is that the case, or if one is reinstated, the second one would be reinstated, or they would have to petition to reinstate the second one?
I'm gonna defer that to our tireless staff and Sotogram because it gets very technical and I don't want to say anything that's incorrect. Anne?
Yeah, so I guess how I would frame it as as a precursor to having an advanced pharmacist practitioner license, you have to have a pharmacist license. So
Agreed.
where a pharmacist license is canceled, the advanced license would be canceled, right?
Mm-hmm.
If you restore the pharmacist license, the advanced is not an automatic.
Okay, that's what I
So
want.
it's automatic one way, but not the other. I don't know that made sense. I'm
I think
hoping
That's
that
what
makes
my
sense.
question was. It makes sense. I agree. That makes sense.
Why are you looking at Corinne? What's going on down there? Hello. Anyway, okay, I think that's clear, hopefully. That's the intent, at least from our perspective. So
Didn't seem like it was very clear, but now makes it. I mean, it makes sense, but I don't know. Maybe
these are all written in a language where it's not that easy for just the normal people like myself to follow along. So I don't
Same
blame you,
here.
Satinder. Yeah, but I guess that's just the way of the law. Okay, members, if we are in agreement, we will bring this to our full board, and at that time, we will continue our discussion and finalize the statutory proposal at that time. So with that, we're ready for public comment in WebEx.
All right, if any member of the public would like to comment, please raise your hand by clicking on the hand icon next to your name, or if you've called in, pressing *3. We are displaying instructions and we'll give you a moment.
I know Dr. Kim had something to say about this, so I want to make sure he's...
He's not
Maybe.
raising his hand, so he may have
It's all
stepped
good.
away.
It's all good. Maybe he spoke his piece.
All
but,
right. I see no raised hands, so I return the floor back to you.
Thank you, Tricia. All right, everybody, thank you. Next is the agenda item 8, discussion of licensing statistics. The meeting materials include a summary of the licensing statistics for the first 5 months of the fiscal year. Given the timing of this meeting and release of meeting materials, data for December was not available. I've asked staff to include the licensing data for December as part of the full board meeting materials and later this month. Processing times for the various facility business types vary and continue to fluctuate. While a few of the licensing programs are within the board's performance targets, others exceed the 30-day target. As a quick reminder, the processing time noted in the meeting materials represents the oldest application of each type. The average processing time is much lower. I really would like to take this moment to again thank you, our licensing staff, for working so diligently to process applications. From my anecdotal conversations, I know that things are a lot better, and I really, really appreciate a lot of the effort. We've had quite a vacancies and significant challenges the last few years, and I'm really hoping that we are on a good setting to continue to get better. In the first 5 months of the fiscal year, the board had issued 4,637 individual licensees and 262 permanent site licenses, with an additional 656 temporary site licenses. I believe these numbers alone demonstrate how busy the board's licensing staff remain. We, after all, is the most populous state in the country. Members, I welcome your thoughts on the licensing statistics. Hearing none, we are ready for public comment Claudia, go ahead.
Yes, thank you. So thank you again to the staff for doing such an amazing job. I mean, these numbers are incredible. But is there anything else that we can be doing to assist the staff to make this more fluid? I know that there was a request for information put out, I think, last year, and there were some vendors that submitted information. Also, just wanted to ask staff if that is part of our ongoing process to look for this new system to help us just have a better process for efficiency, or is it long-term more looking at just standardizing our process with newer technology?
Thank you, Claudia. Great comment. Anne?
So business modernization will be key to the board's success in,
Period.
achieving some
I'm just kidding.
efficiencies on application processing and standardizing some of it, and being able to leverage technology in a new way will really help benefit us long term. But it's a multi-year process, that business modernization effort.
That's right. So we're looking at maybe 2 to 3 years, but for now everything is working and we're keeping the dates pretty low. So, any other things that we should be looking at to help the staff improve?
So at the staff level, we're always looking at ways to look for like common deficiencies and see if there's different ways for us to present the information in the, in the instructions. So when we recently made changes to the pharmacy instructions and application, that has actually served to benefit applicants in better understanding. And we would say that some of the applications that are coming in now specific to that license type, there's been improvement. So we continue to look for opportunities to make changes where we can within items that are within our control. With the exception of the pharmacy technician application, we have good flexibility to update. Pharmacy technician applications are a little more difficult because we do have to go through the full rulemaking process, but we do try to, leverage that opportunity as well. So we do have an active rulemaking in that area to streamline.
That's great. And in terms of the license process, when somebody's applying and they need to get a hold of staff, how does that process work in terms of customer service really quickly? And just to kind of visualize
So primarily it is through email. We do have, that's probably more detail than you want to know, but we do have a Teams channel that we use. So when someone calls in, we do have a way to identify, someone to answer that call. Because we do have a high volume of work, we do prefer email so that we have an opportunity to, continue what we're doing and then pivot to that. We also do encourage, where possible, especially for our more complex license types, to schedule a meeting and really talk through, especially for pharmacy, where it's a pretty complicated process because of the regulation and how the board is structured. We do find that a meeting, a scheduled time where it's dedicated to that purpose, is both beneficial to board staff as well as to the applicants and helps guide them a little bit better.
Thank you. I really appreciate that. It sounds like we make ourselves accessible and we allocate time to make sure everything is in order before they even apply or as they're applying. So that's great. Thank you so much.
Thank you for the comment. Some are really complex processes, as you can imagine. Certain PHYs pharmacies have multi-layered ownerships and different owners with percentage, and our laws are very specific to what is required and what information we need to gather. And also we really are, at the forefront of getting as much as we can in ensuring that there's no problems, no histories, right? There's a lot of things that go on with so many hands and a lot of enforcements as well related to it. So this is really, really quite a bit of extensive involved work, and for that our staff does a phenomenal job of trying to keep up with everything, and I really appreciate it. And thank you for the questions there, Claudia. That's appreciated.
Thank you.
Okay, we're ready for public comment. Public comment in WebEx, please.
All right, if any member of the public would like to comment, please raise your hand by clicking on the hand icon next to your name, or if you've called in, pressing *3. We are explaining instructions and we'll give you a moment. All right, I see no requests for comment. I return the floor back to you.
Thank you, Trisha. Okay, members, here we are. I'm happy we got done before noon, so I hope you all enjoy your lunch. And next agenda item is 9, future committee meeting dates. Our next meeting is scheduled to be April 15th of 2026. Please monitor for board's website for any updates. And meeting is adjourned. Everyone, Happy New Year. We'll see you all in person in Sacramento. Hopefully it'll be sunny. It's been quite dreary everywhere. So I think we're gonna see you all on January 26th and 27th at the full board meeting. And some of you enjoy your public education committee meeting that's starting at 2 o'clock. Thank you all. Have a great day and Happy New Year.
Thank you.
Happy New Year. Take care, everybody.